Hi, everyone. Thank you for joining today's web interface support call for ACOs, groups, and virtual groups. During this session, CMS will highlight important information and updates on reporting quality data through the CMS Web Interface for the 2021 performance period. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions via phone in the support call questions box, and CMS subject matter experts will address as many questions as time allows. You're welcome to submit questions during the presentation or wait to submit your questions until the Q&A portion of the call. Now I will turn it over to Lisa Marie Gomez at CMS to begin.
Welcome everyone, and thank you for joining us today as groups, virtual groups, ACOs, and other APM entities prepare for CMS Web Interface quality reporting. Again, I'm Lisa Marie Gomez from CMS, an expert on the CMS Web Interface. Joining me on the call today are other experts who will share helpful information on CMS Web Interface quality reporting and answer your questions during the question and answer session after today's presentation. Today's call will only focus on 2021 quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or other quality reporting questions that you may have. Next slide, please. This is a disclaimer slide about this presentation. Information in this presentation is current at the time it is published, but I urge you to please be sure that you're using the source documents and links that are provided throughout the presentation, and please stay tuned to any communication from the Quality Payment Program or Shared Savings Program ACOs regarding any updated information. Next slide, please. For the next couple of slides, I will highlight important announcements and reminders. Next slide, please. The CMS Web Interface will close at 8 p.m. Eastern Time on March 31st, 2022. Your submission will be automatically accepted at submission close. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website circled here. Next slide, please. Transition webinars for the sunsetting of the CMS Web Interface for groups and virtual groups will be held on Wednesday, February 2nd, 2022, and Wednesday, February 16th, 2022. Shared Savings Program ACOs will be able to use the CMS Web Interface through the 2024 performance period. The Shared Savings Program ACOs are welcome to attend the transition webinars if they would like to learn more information immediately about other collection and submission types. Otherwise, they don't need to necessarily attend. For today's support call, we will cover the following topics: other CMS approved reason requests, frequently asked measure questions regarding telehealth for CMS Web Interface, Prev 5, breast cancer screening, and Prev 12, preventative care and screening for depression and follow-up. The next support call will be held on Wednesday, February 9th, 2022, from 1 to 2:30 p.m. Eastern Time. Topics will include Prev 12, which is prevention, care, and screening influenza immunization, and DM2, diabetes, hemoglobin A1c port control. All additional topics may be added prior to the support call. Next slide, please. The 2021 CMS Web Interface measure specifications and supporting documents were published on the Quality Payment Program Resource Library in December of 2020. These documents include the submission release notes and the coding release notes, which outline any changes that were made to the specifications and coding documents from the 2020 performance period to the 2021 performance period. There were no substantive annual changes to the 2021 measure specifications. The coding documents were updated with annual coding changes. However, the coding update did not change the intent of the measure. Medical record documentation is always necessary to support the information reported within the CMS Web Interface. Next slide, please. The 2022 CMS Web Interface measure specifications and supporting documents are now available on the Quality Payment Program Resource Library. We encourage you to review all updated documents early each year to review the changes that occur between performance periods. The 2022 measure specifications and supporting documents referenced on this slide are applicable to the 2022 performance period and shouldn't be used for the 2021 performance period or submission. Next slide, please. The CMS Web Interface API is available all year for testing in the developer preview environment. Please review the links listed here for more information. Next slide, please. Now I will turn the presentation over to Katie Moore, who will go over other CMS approved reason requests and frequently asked measure questions. Katie?
Thank you, Lisa Marie. This is Katie Moore from the PIMS team. I'm going to go over the other CMS approved reasons requests and frequently asked measure questions. Next slide, please. So here we're just going to cover what an other CMS approved reason request is. Some patients may be skipped from a measure because they don't qualify for that particular measure or the sample. Each measure displays a list of the specific reasons why a patient may not qualify for the measure. By requesting an other CMS approved reason, it's a way to skip a patient attributed to a measure that's reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or denominator exceptions identified within the measure specifications. An other CMS approved reason request must be submitted through the CMS Web Interface, and we ask that you provide detailed information about why the patient should be skipped. It isn't necessary to request an other CMS approved reason if there's an applicable denominator exclusion, an applicable denominator exception, or the patient is not qualified for the sample. And these instances would include if the patient is deceased, in hospice, moved out of the country, or didn't have Medicare fee-for-service as their primary payer. It will also be skipped if the pre-populated demographic information isn't accurate, for example, a birth date or gender as it relates to Prev 5. For more information on how to submit an other CMS approved reason request, we suggest that you view page 52 in the 2021 CMS Web Interface User Guide. Next slide, please. So once submitted, additional information may be requested from the submitter via email from the PIMS Quality Measure Support mailbox. These inquiries are sent to the address entered by the submitter when they're filling out the skip request. So we ask that you reply with the information requested as soon as possible. And if you have any questions related to your skip request, you can always submit a question to the service center at qpp@cms.hhs.gov. If there's multiple requests for additional detail that are unanswered, the request will move forward in the review process using the information provided. And once a decision has been issued, the request cannot be reopened. So we ask that you are responsive to those questions if you do see those come through. If an other CMS approved reason request is approved, the patient will be skipped and another patient must be reported in their place for the measure if available. If the request is denied, the patient will remain incomplete until you complete reporting on the patient. We would also like to note that submitting your request for an other CMS approved reason during the last days of the submission period could cause your request not to be processed, so that we ask you submit your request as soon as possible. Next slide, please. Now we're going to cover some frequently asked measure questions. Next slide, please. First, as it relates to telehealth for the CMS Web Interface, we'd like to remind you that for numerator compliance when reporting using the CMS Web Interface, a telehealth encounter may include medical information obtained over the phone, email, or other electronic communication used to interact with a patient. These are not limited to billable Medicare telehealth visits. The medical record must reflect the information reported within the CMS Web Interface. There's only one 2021 CMS Web Interface measure, which is Prev 13, that does not allow the quality action to be completed during a telehealth encounter. The specification contains specific guidance indicating the documentation of statin therapy prescribed or being taken during the measurement period cannot be performed during a telehealth encounter. And we recommend reviewing the 2021 CMS Web Interface telehealth document for more information. Next slide, please. Now we're going to cover PrEP5 breast cancer screening. Just as a reminder, the intent of this measure is for women 50 to 74 years of age to have screening mammogram for breast cancer during the 27 months prior to the end of the measurement period. In terms of telehealth for PrEP5, documentation of the screening for breast cancer may be completed during a telehealth encounter. The medical record documentation must include the date the screening was performed, type of test, and the result or finding. Next slide, please. Question number 1. For the 2021 CMS Web Interface PrEP5 measure, does a unilateral mammogram count for the numerator? The answer is that a unilateral mammography counts only if there's medical record documentation of a mastectomy or the other breast. If only one breast is present, unilateral screening, or one side, must be performed on the remaining breast. Question 2. The 2021 CMS Web Interface PrEP5 coding document contains HCPCS codes G0202 and 0204 and 0206 as unacceptable for the numerator to reference mammography screening. However, these 3 codes aren't valid after 2017. Can we use the CPT codes? If you're mapping to an EHR, report based on the 2021 CMS Web Interface PrEP5 coding document. The coding provided is considered all-inclusive for purposes of mapping to an EHR. If you're not mapping to an EHR, the coding must be used as a guide to assist in reporting. Other codes representative of the numerator quality action, denominator inclusion criteria, or referenced exclusions or exceptions may be used to assist in locating the required medical record documentation. Next slide, please. Question 3, the description of the 2021 PrEP5 measure specification states women 50 to 74 years of age, while the initial population states women 51 to 74 years. Which is correct? The answer is that the patient isn't considered eligible for the denominator until the age of 51, but mammograms received beginning at age 50 can be used to satisfy the numerator. The look-back period allows for a mammogram during the measurement year, the year prior to the measurement year, and a 3-month grace period for a total of 27 months. Question 4, is it acceptable for the patient to report previous receipt of a mammogram, and can it be done during a telehealth visit? The answer is yes, as long as the documentation includes the date, type of test, and the results or finding. Documentation of normal or abnormal is acceptable. Documentation of screening for breast cancer may be completed during a telehealth encounter. Next slide, please. Question 5 is, how is CMS handling gender identity related to quality metric inclusion? Do you only follow the legal sex, or are other identifiers considered? The answer is that generally, CMS considers the patient's gender at birth for inclusion in the denominator. If there's an instance where the patient was sampled for the measure, but you don't believe they should have been, if they were born male or identifier have transitioned to female, we suggest submitting a skip request for other CMS-approved reason to skip the patient, and CMS will evaluate these on a case-by-case basis. In the instance the patient's demographic information is incorrect, it can be fixed within the CMS Web Interface. Note that any demographic information you change in the CMS Web Interface doesn't get reported back to the Medicare Patient Enrollment Database. You should encourage your patient to contact the Social Security Administration directly to have such information updated. Next slide, please. Now we'll be discussing PrEP12, preventive care and screening for depression and follow-up plan. The intent of this measure is to screen patients aged 12 years and older for depression, and if positive, document a follow-up plan. In regard to the use of telehealth for Prev-12, a screening for depression may be completed during a telehealth encounter. Documentation of a recommended follow-up plan for positive depression screen may be completed during a telehealth encounter. Next slide, please. And we would like to note the following changes will be applied to Prev-12 for the 2021 performance period. It will be excluded from MIPS scoring, provided that the measure meets the data completeness requirement, And in regard to documentation submission for the 2021 Prev-12 measure, the following will apply. For CMS Web Interface users with an EHR that currently reflects the 2018 Prev-12 measure specifications, CMS will accept the same types of documentation submitted during the 2018 submission period for the 2021 performance period. For web interface users with an EHR that currently reflects the 2019, 2020, or 2021 specifications, CMS will accept documentation that aligns with those versions of the measure specifications. Next slide, please. In terms of our frequently asked questions, number one, this relates back to the information just shared on the previous slide, that CMS will accept the same types of documentation allowed for the 2018 submission period for the 2020-21 performance period. This includes conducting a PHQ-9 as follow-up for positive PHQ-2, as it has in the past. Instances where both questions on the PHQ-2 are both answered no can be assumed negative. A screening score of 0 can be assumed negative, and it's acceptable if the name of the tool isn't documented, but the same questions are built into the EHR. Question 2, can documentation of a follow-up plan be used to infer a depression screening was positive if no results are documented? The answer is no. A clinician's interpretation of the results is required. Next slide, please. Question 3, the 2021 Prev-12 measure specification states that the screening results must be reviewed and documented by the eligible professional in the medical record on the day of the encounter. What is the definition of an eligible professional? So the 2021 Prev-12 measure specification states the results must be reviewed and documented by the eligible professional in the medical record on the date of encounter to meet the screening portion of the measure. The intent of this statement is to clarify that the quality action should be completed by an eligible clinician. However, others within your organization may complete the quality action. The quality action can be completed by anyone the organization considers qualified. Question 4, previously a follow-up plan had to be documented on the date of a positive screen, but for 2021, the measure specifications state it must be documented on the date of eligible encounter. Is that correct? For 2021 Prev-12, a follow-up plan can either be documented on the date of positive screen or during a documented encounter, either telehealth or office visit. Next slide, please. Question 5, does a certain condition, for example, intellectual disability, impairment, Alzheimer's, dementia, autism, qualify a patient for denominator exception or exclusion? In this instance, a denominator exclusion would only apply to patients with an active diagnosis for depression or a diagnosis of bipolar disorder. The specification doesn't define denominator exceptions by specific diagnosis. If the patient qualifies for the measure and there's medical record documentation the patient wasn't screened for depression due to situations where the patient's functional capacity or motivation to improve may impact the accuracy of the results of the standardized depression assessment tools, then it would be appropriate to select the denominator exception. For this example, the denominator exception could be claimed if there is medical record documentation stating the patient wasn't screened due to the patient's diagnosis, resulting in their inability to appropriately respond to the questions. Next slide, please. Okay, that is the end of our frequently asked questions. I will turn things back over to Lisa Marie. Thank you.
Thank you, Katie. The next few slides, we will outline the available CMS Web Interface resources. Next slide, please. Please note that 2021 resources are available on the Quality Payment Program Resource Library. We encourage reviewing these documents if you have questions on quality requirements and measures. We'll continue to communicate any future postings and upcoming support calls. Additionally, the Help and Support page on the Quality Payment Program website contains links to materials such as videos, webinars, and online courses, as well as other items to help with reporting and development. Next slide, please. This slide contains links to resources available for the Shared Savings Program, specifically for ACOs. We encourage you to review the materials available here for more information. Next slide, please. If you need additional assistance, please refer to the contact information listed on this slide. Next slide, please. Now, just before we go into the Q&A portion of this call, if you're interested in providing feedback and collaborating with CMS on the Quality Payment Program, we encourage you to participate in our human-centered design efforts. To get involved, please email your name, title, topic of interest, and organization to qppuserresearch@cms.hhs.gov. Now I will turn the presentation over to Emily Schutz to begin the Q&A session.
Thanks, Lisa Marie. We're now going to start the Q&A portion of the webinar. You can ask questions via the Q&A box or through the webinar audio. To ask a question via the webinar audio, please raise your hand and we will unmute your line so that you can speak. To submit a question anonymously via the Q&A box, please click Send Anonymously. Otherwise, all attendees will be able to view your question. So I guess we can go ahead and get started with some questions that have already been submitted. So the first question that we have says, if a letter from a patient's OBGYN states the patient had a normal mammogram, is that acceptable to say yes to the PREV5 measure?
Hi, this is Angie from PIMS. It is, as long as the medical record documentation includes the date of the breast cancer screening and the result or findings, which can just be normal or abnormal. So if that's part of the medical record, it can be used. Thank you.
Great, thank you so much for that response. I'll move in to the next question now, which is on PREV10. And the question says, last year, the measure was modified during a support call to say never a smoker. Does this count for the tobacco screening, or does count for the tobacco screening? Is that the case for 2021 as well?
The intent of the measure specification is to determine if the patient was screened for tobacco use. Therefore, as long as the clinician has documented a status for any type of tobacco use, that meets the performance requirement for the screening component of the numerator.
Great, thank you so much. Our next question is GRPO affected by any of the 2021 suppressed measures?
Hi, this is Katie from the PIMS team. So just to reiterate what we just covered in regard to PREV12, the measure will not be scored for the 2021 performance period. In addition to the two measures that are typically not scored for web interface reporting. Thank you.
Great, thank you, Katie. Our next question is, for HTN2, we have a lot of blood pressure readings from nurses' notes, which are notes just for blood pressure checks. These notes are not signed. Would this be accepted for the blood pressure reading if it is the last one of the year, even if it is not a signed note?
Yes, this measure does not provide the specifics of medical record documentation. So as long as the medical record documentation is present and it is the most recent blood pressure, that would meet the intent of the measure.
Great, thank you for that clarification. Our next question says, last year during a support call, there was clarification that there is no definition for remote monitoring. So if a clinician accepts a patient taking their own blood pressure, this could count. Is this the same for 2021?
So for 2021, MIPS quality measure, hypertension 2, controlling hypertension. The denominator includes telehealth encounters and a blood pressure taken by either a clinician or a remote monitoring device, home device or device brought by the visiting nurse or caregiver and conveyed by that nurse or caregiver or by the patient to their clinician is acceptable for the numerator as long as it is the most recent blood pressure reading documented in the medical record for the patient during the measurement period. And since the measure guidance and specifications do not define what constitutes a remote blood pressure device or method of conveying the blood pressure from a remote monitoring device to the clinician, we're unable to provide guidance on the specific devices or specific workflow on how the clinician interacts with patients using remote monitoring devices during a telehealth encounter. It is to the clinician's discretion as to whether the remote monitoring device used to obtain the blood pressure is considered acceptable and reliable.
Great, thank you so much. And so just to clarify, does this mean that a hypertension reading could be from a telehealth encounter as well?
I'm sorry. Yes, that is correct.
Great, thanks so much. So our next question says, if a patient is screened for depression using PHQ-2, but has no indication of interpretation, can this be accepted if by policy a 0 would equate to a negative?
Hi, this is Katie from the PIMS team. So I think in this one we would need a little bit more information. We do have guidance saying that if the answers to the questions are no or 0, that can be interpreted as a negative screening for depression. So in that instance, it would be accepted. If there's further questions as it relates to certain policies that are implemented by your organization, we would suggest that you submit those to qpp@cms.hhs.gov so that we can look into that a little bit further. Thank you.
Great, thanks so much for that response. So I think next we're going to go to some questions on the phone. So if you do have a question you would like to ask via the phone line, please go ahead and raise your hand. And it looks like, oh, yeah.
Oh, excuse me. This is Sandra Slaughter from the Shared Savings Program. If I could just, before we go to the phone, a legacy term was used in one of the earlier questions, GPRO, GPRO, and I just wanted to say that that is a term that is a legacy term, and it means group practice reporting options. So if you ever see that, you could just think of the web interface. So anyway, I just wanted to define that for anyone who may not be familiar. Thank you.
Thank you, Sandra, for that clarification. So it looks like the first hand raised I see is from Brian Heck. So I'm going to go ahead and unmute your line. And Brian, you may be double muted. We're having a little trouble hearing you. Well, it sounds like there may be some audio issues, so we will come back to Brian and head to our next question that's on the phone line. And again, please go ahead and raise your hand if you do have a question that you would like to ask live. And it looks like our next question with a hand raise comes from Joseph Bartman. So Joseph, I'm going to go ahead and unmute your line. And Joseph, you will need to enter that audio pin you were just sent in order to speak on the line. All right, and we'll give Joseph a moment to get on the line. Next, we'll move to Karina Magaziner-Rubin. Karina, I'm going to go ahead and unmute your line so that you can speak. Karina, you are muted, so you will have to unmute your line.
Oh, hi. My name is Betty, actually. I had a question on impairs. We have like a weird thing going on here. On one of our patients, we're seeing like they have Anthem as primary. It's like Anthem Blue Cross Blue Shield. But on the back of the card, it says to bill Medicare as primary, and then they pick up all of the bills after that Medicare A and B doesn't cover. So we wanted to make sure we're doing our making sure we're doing the right thing here, because we really look for Medicare traditional A and B as to be primary. So wasn't sure if this would be one that would be excluded, or would it actually be included for the CMS abstraction?
This is Kara with RTI. If the primary coverage is Medicare fee-for-service for the entire measurement period, there would be no reason to remove the patient. And if that Anthem coverage is supplemental coverage, Medicare fee-for-service is still the primary coverage. Therefore, any patient with supplemental coverage should not be disqualified. If the primary coverage was non-Medicare or Medicare Advantage for at least some portion of the year, then it would be appropriate to exclude the patient from the measure.
Okay, I think that's where we're trying to figure out it is, because it does have it marked as Anthem Blue Cross Blue Shield as primary, but then again on the back of that card it says to bill Medicare first. So I think that's where some of our confusion was at. So I wasn't quite sure what to do with that.
Yeah, if you want to submit a ticket and we can explore further, please go ahead. I guess the question is whether is this truly supplemental coverage or some other kind of coverage.
Okay, thank you.
Great, thanks so much. So next we'll take a couple more questions on the phone, and it looks like Krista Curtis has your hand raised, so I'm going to go ahead and unmute your line so that you can speak.
Hi, I have a question that pertains to Prev 12, and it was actually covered in the frequently asked questions, but I just want to make sure I understand that the PHQ2 will count as the screening and a subsequent PHQ9 will count as the follow-up. Is that correct?
Hi, this is Katie from the PIMS team. That is correct for 2021 reporting, and I do want to know that is due to there being no substantive changes to the measure specifications for 2021. So that relates back to an issue that was identified where the coding for that follow-up was removed from the coding documents, but the language within the specification still didn't seem to entirely match with that. So for 2021, that will be acceptable.
Thank you.
Thanks so much. And we'll do one more question on the phone. Marisha Smith, you are up next, so I'm going to unmute your line so you can ask a question.
All righty, can you hear me?
Yes, we can.
Perfect. Also on the Prev 12, I know it was mentioned earlier that a score of 0 was an assumed negative. Is there a max score that would be an assumed positive?
Hi, this is Katie from the PIMS team. So In that instance, we would refer you back to the specific tool that you're using for screening, along with the provider's interpretation of negative or positive. The measure specification doesn't outline a specific score for a positive screen, so that would really be up to the clinician's interpretation.
Okay. And just a follow-up, if the clinician did not indicate positive or negative, there wouldn't be a max score for that.
Sure. Yeah, if the clinician didn't indicate positive or negative, it would be treated as though the screening wasn't completed because there'd be no documentation to support that the screening was completed. The measure specification does require that documentation of positive or negative by the clinician.
Perfect. Thank you.
Great, thanks so much for that response. And we'll do one more question from the phone line. Sandy Santangelo, I'm going to unmute your line so that you can ask your question.
Thank you. I appreciate getting the question. So I just have a question to go back to the hypertension question and telehealth and patient reported. I appreciate the answer, excuse me, that was given. I'm wondering, where can we find that in writing? Because it was a lot to try to jot down and absorb. I just want to make sure that we're capturing the information correctly.
If you could send in an inquiry, or if you would send in a ticket, I can provide that information to you as well.
Perfect, will do. Thank you so much, appreciate it.
Not a problem.
Great, thanks, Sandy. So we're going to move back to some of the questions we've received through our Q&A box. So the first question states, we have claims information for some of our measures. Would the claims information by itself be accepted, or would we need to go and find the information to back up the claims information too?
Hi, this is Angie from PIMS. So no, claims information alone cannot be used to do web interface quality reporting. When submitting the data through the CMS Web Interface, the expectation is that medical record documentation is available that supports what's reported to the web interface. And claims can't be used to confirm a diagnosis, for example, for the diabetes measure or the hypertension measure, because it's used for sampling purposes. Claims are used for sampling purposes, and that's the original source of the sampling diagnosis. So then the expectation for reporters is that they would have medical record documentation to substantiate that, you know, the diagnosis for a measure or any other, the quality action. So you always would need medical record documentation to back up anything reported. Thank you.
Thanks, Angela. And I think we have another question for you. For the web interface for MH1 inclusion diagnosis, finding F32.9 coded on encounters, but description isn't stating major depression, only depression unspecified. Would that still count for inclusion?
The codes that are included in the measure can be found in the MH coding document, the 2021 coding document. So those codes and diagnosis descriptions are valid for the measure. If you look on page 9 of the measure specifications, there's also some denominator guidance that says that the diagnosis code on the encounter problem list can be used, it says, regardless of vendor assigned description of the code. So the code, first of all, would have to be on the coding document. The words major depression, major depressive disorder, dysthymia, dysthymic disorder, pervasive depressive disorder on the progress notes or problem list, they can be used to confirm the diagnosis. In paper records, the description depression may be used with the option to confirm by diagnosis code. So it can be a combination of a code and a description in the medical record, but first of all, that the measure does call for major depressive disorder. So that's what we're looking for, to include those patients in the denominator. I hope that made sense. Thank you.
Thanks, Angela. And I think we have one last question for you. For PREV5 breast cancer screening, for patient reporting documentation, the type of test is needed. Would documentation of mammogram 1230/2020 normal be compliant for this measure, or would the type of test need to state bilateral mammogram?
So according to the measure specifications, mammography screening is defined as bilateral. So the only time that it wouldn't be defined as bilateral is if there was documentation that the patient had had a previous unilateral mastectomy or a situation like that. So as long as the type of test, mammography, the date, and the results of normal or abnormal are documented, it can be used. Thank you.
Thanks so much. Our next question says, if a patient's complete the PHQ-9 or PHQ-2 in the last 2 weeks prior to the performance year and returns it via patient portal, does this meet the measure specification?
Hi, this is Katie from the PIMS team again. So in terms of telehealth for the CMS Web Interface, we do want to reiterate that for numerator compliance, a telehealth encounter could include medical information obtained over the phone, email, or other electronic communication used to interact with the patient. And then to satisfy the numerator for PREV12, the screening for depression may be completed during a telehealth encounter, and then documentation of a recommended follow-up plan for a positive screen may be completed during a telehealth encounter. So we would just need to ensure that all of the components of the measure are captured, the screening was completed, there's documentation of negative or positive, and then that follow-up plan, if the depression screening is positive, would also need to be documented. Thank you.
Great, thanks so much, Katie. And we have one more question for you. This is a clarifying question that asks, did you say that if a PHQ-2 was completed and the interpretation was negative for depression, it meets the measure?
Yes, so this goes back to the acceptable documentation from 2018 still being acceptable for 2021 since there were no substantive changes to the measure. So in this instance, if the PHQ-2 is 0, that can be assumed negative. Thank you.
Emily, for this particular question related to PREV12, can we just go quickly to go back to slide 20? I know several folks are asking to see slide 20, particularly as we talk about PREV12.
Absolutely. Slide 20 is showing on the screen now.
Great, thank you.
No problem. We will go ahead and move into our next question, but I'll keep this content on the screen. Our next question asks, regarding CARE 2 for performance year 2021, is it mentioned that an assessment of gait and balance will count towards the numerator? What about a comment referencing patient ambulates normally?
Hi, this is Carol from the PIMS team. Medical record documentation of gait is normal would meet the intent of the measure and address that the patient has been screened. The use of assessment is not specific to the use of a screening tool, but may also include an assessment performed with or without a screening tool by the clinician.
Great, thank you so much for that clarification. So we have another question that has come through the Q&A box, and it says, for the telehealth encounter definition, it was said that it does not have to be billable and over the phone is acceptable. Would this also count for blood pressure readings, meaning a clinician can call a patient to get a blood pressure reading just via the phone call and document this in the patient's chart?
That is correct. Information can be obtained over the phone or via email. Telehealth encounters for the CMS Web Interface are not limited to medical billable encounters. So when submitting data through the CMS Web Interface, the expectation is that the medical record documentation is available that supports the action reported in the CMS Web Interface. That's it. Thank you.
Great, thank you for that response. So we're going to move back to the phone line now and answer some questions for folks who have their hands raised. So Chantel Burke, I see that your hand is raised, so I'm going to go ahead and unmute your line. And you will have to unmute yourself as well to speak on the line, Chantel.
There we go. Thank you. Can you hear me?
Yep.
Great.
Yes,
so I have a question about the depression screening. An example would be that the patient did receive the depression screening. The score was noted as a 2, but in the note, it is not documented as negative or positive. So in that instance, would we say that the screening was not done, or would we say that the screening was done, it was positive, and there wasn't a follow-up associated with that positive screen?
Hi, this is Katie from the PIMS team. Can you repeat your question one more time for me?
Sure. So in the instance of a depression screening, the provider performed the screening. The result was a 2. In the note, it is not documented that the result of 2 is identified as a positive screen or a negative screen. So when we're answering the questions, should we indicate that the screening was not done because there is no interpretation to the 2 result, or would we say that the result of 2 is positive, but there was no follow-up if there's no documentation of a follow-up performed?
Sure. So again, for this measure, it doesn't go by specific scores, so it does look for that interpretation of negative or positive. So if there's no interpretation by the clinician, it would be viewed as though the screening was not performed.
Okay, great. Thank you.
Thanks for that question. We're going to go with another question from the phone line. So Ramonda Mowdy, I see that your hand is raised, so I'm going to go ahead and unmute your line. Ramonda, we're having a little trouble hearing you. You may be double muted. Okay, we need to come back to Ramonda for your question. So next on our list is Joseph Bartman. I'm going to go ahead and unmute your line.
Hi, thank you. So for Prev 12, we found a patient and a diagnosis was identified as it relates to potentially a denominator exclusion of schizoaffective disorder of bipolar type. That code is not specified on the coding document as an applicable exclusion code. However, when you look at the measure specs, it does appear the intent of the measure is to exclude those with a bipolar type disorder. So could you advise when we're finding that diagnosis if that would count as an exclusion, even though not in the coding document?
Hi, this is Katie from the PIMS team. So if you have medical record documentation supporting a diagnosis of depression or bipolar disorder, then you would be able to use that to support the exclusion. It's not limited specifically to the coding documents as long as your medical record documentation supports that the exclusion would apply.
Okay, thank you.
Great, thanks so much for that question. Next on our phone line, we're going to go to Rick Bukowski. I see that your hand is raised, and I'll unmute your line now. And Rick, you may be double muted. We're having some trouble hearing you. Okay. We may need to come back to Rick's question. So next on the line with their hand raised, we have Laura Tidwell. So I'll go ahead and unmute your line now.
My answer was already answered in the chat. Thank you.
Great, no problem. So then we will move on. We'll take one more question from the phone line. So Prathima Pichera, I see that your hand is raised, and I'll go ahead and unmute your line now.
Can you hear me?
Yes, we can.
Yes, so I'm just going to take a A1c measure as a reference. I see in initial population that patients 18 to 75 years of age with diabetes with a visit during the measurement period. So I have a question regarding that visit. We did the question and hear back from the QPP. My question is that when we receive the beneficiary sample from the claims information, it's already made sure that they had a visit with our ACO providers, or do we have to actively look to make sure they had a visit during the measurement period?
This is Kara Sokol with RTI. By virtue of being sampled into the web interface, CMS has identified claims for these patients submitted by your organization. So in order to be selected for the web interface sample, these patients must have had at least 2 eligible services within your ACO during the measurement period. So you do not have to confirm the visit.
Okay, thank you.
Great, thanks so much. And we have time for one more question from the call-in line. So Gina Bodycott, I see that your hand is raised. So I'm going to go ahead and unmute your line now so you can ask your question.
Hi, can you hear me okay?
Yes, we can.
Okay, so I know in the 2019 interpretation of the 2018 guidelines, it was identified that if a interpretation on Prev 12 was 0, it needed to be interpreted. But in subsequent years, it's my understanding, based on the documentation I have from these sessions, that a 0 could be counted as interpretation of. That was the only score that did not have to be interpreted. Are we rescinding that, or are we? I need clarification on that. That's a very important point. So we've had it both ways. So I'm just looking. Thank you.
So this is Katie from the PIMS team. I believe the guidance has always been that PHQ results of 0 can be assumed negative, and that would be true for 2021 as well. Any other numerical score would require interpretation by the clinician.
Okay, thank you very much.
Thank you.
And Emily, before we go on to the next question, I know that we continue to receive questions relating to Prep 12, there are folks that are asking to see slide 19, so if we can just move to slide 19 as we continue on the discussion with the other questions in the Q&A box. Thank you.
Absolutely. Slide 19 should be showing on your screens now. And we will go ahead and move back into the questions submitted through the Q&A box and respond to some of those. So the next question to come in asks, for a mammogram, is the month and year acceptable along with the results, or do we need the exact date?
Hi, this is Angie from PIMS. The month and the year at the very least would need to be included to support that the breast cancer screening was done during the 27 months prior to the end of the measurement period. So month and year at the very least. Thank you.
Great, thank you, Angela. So our next question that has come in asks, can we use a blood pressure from a specialist office if it is the last blood pressure of the measurement period?
Yes. Yes, you may.
Great, thank you for that clarification. And one more clarifying question about that. This question asks to clarify, does that mean that a patient reported blood pressure using a remote monitoring device can be counted?
Oh, I'm sorry, didn't get off mute there, but yes, that is correct. Since the measures or the measure itself, the guidance and specifications do not define what constitutes a remote monitoring device or method of conveying that blood pressure from a remote monitoring device to the clinician, then we're unable to provide, I guess, specific guidance on what types of devices and so on. So yes, it would be acceptable.
Great, thank you. And we have another question about the blood pressure screening. This question asks, in regards to HTN2, in the past we could use blood pressures from ED, IC, inpatient encounters, but didn't have to if it was too high. Is this still acceptable?
So no, there is guidance within the measure specification, I believe page 8, that is specific to ED visits that are not to be included. Urgent care, however, is included. So I would say to refer back to the measure specification for those types of, actually it's on page 10 of the measure specification. Sorry, I just found that. So yeah, blood pressure is taken during an acute inpatient stay or during an ED visit are excluded.
Great, thank you for that clarification. Another question has come in through the Q&A box, and this question asked, for the depression remission measure, does the diagnosis have to specify major depression for the measure, or does depression need to be addressed?
Hi, this is Angie. Yes, the patients that have an active diagnosis of major depression or dysthymia during the denominator identification period would be included in the measure. And again, you can refer to the coding document for diagnosis codes and descriptions included in the measure. Thank you.
Great, thanks so much for that clarification. We have another question that asks, for HTN, if you can't confirm diagnosis in the first 6 months of 2021, but confirmed in 2020, we need to take this next step to confirm in the last 6 months of 2021 to meet the element of didn't end before the start of 2021 to completely confirm the diagnosis. Is that correct?
So yes, so the time frame for the patient with a diagnosis of essential hypertension is within the first 6 months of the measurement period or any time prior to the measurement period but it just cannot end before the start of the measurement period. And you can refer to page 8 for denominator confirmation on that specific one.
Great, thank you. Our next question asks, is the HbAC1 poorly controlled a suppressed measure this year like the PREV-12 measure and will not be scored for 2021?
Hi, this is Jamie. This measure will be scored for 2021. That's it. Thank you.
Great, thank you, Jamie. Our next question asks, can a patient be excluded from the MH1 measure if they have a history of bipolar disease?
Hi, this is Angie. The answer is yes. Wait a minute here. Yes. Patients with a diagnosis of bipolar disorder are listed under the exclusions, and you can verify the coding required, and diagnosis required again on the MH1 coding document on the Denominator Exclusion tab. Thank you.
Great, thanks so much. Our next question asks, does Alzheimer's count as an exclusion for PREV-12?
Hi, this is Katie from the PIMS team. So the exclusions for PREV-12 include a diagnosis with an active diagnosis for depression or a diagnosis for bipolar disorder. There's no specific exclusion for Alzheimer's. However, if there's documentation in the patient's medical record that the patient was not screened due to their diagnosis, this could potentially be included as a denominator exception under situations where the patient's cognitive capacity, functional capacity, or motivation to improve may impact the accuracy of results of the standardized depression assessment tools. So it could potentially fall under that, but what we would really need to have is the documentation that the patient was not screened due to their diagnosis. So that would need to be in the medical record. Thank you.
Great, thanks for that.
Angie from PIMS. I'm sorry, it's Angie from PIMS. Can I go back to the last MH1 question right before Katie? I just wanted to provide some additional information on denominator exclusions for MH1. What I said was correct about the bipolar diagnosis, and denominator exclusions, you must have the denominator exclusion diagnosis anytime prior to the end of the measure assessment period. So as long as it was during that period of time, it would count as an exclusion. Thank you.
Great, thank you for that clarification. We'll do a couple more questions from the Q&A box. So our next question that's come in asks, if the patient's PHQ-2 is 0, does that count as automatic interpretation? This did count in the 2019 guidance.
Hi, this is Katie again. So yes, that would be correct. The prior guidance would still stand for 2021. If the PHQ-2 is 0, it can be interpreted as a negative depression screen. Thank you.
Great, thank you. So our next question from the Q&A box asks, for the HTN2, please clarify if blood pressures taken by a patient using their home blood pressure cuff will count as a blood pressure taken using a remote monitoring device.
So since the measure guidance and specifications do not define what constitutes a remote monitoring device or method of conveying the blood pressure from a remote monitoring device to the clinician, we're unable to provide guidance on specific devices or a specific workflow on how the clinician interacts with the patients using remote monitoring devices during a telehealth encounter. It's up to the clinician's discretion as to whether the remote monitoring device used to obtain the blood pressure is considered acceptable and reliable. Thank you.
Great, thanks so much. So our next question is about Prev 12, and the question asks, for Prev 12, if the member is seeing specialists and they are billing for major depression, but we don't have any medical records for this diagnosis in the chart, would the member count for the measure?
Hi, this is Katie from the PIMS team. So again, we would need you to have that medical record documentation supporting an applicable exclusion for the measure. So if you don't have the appropriate information to support reporting the exclusion, we wouldn't recommend doing so. So it would really be up to your organization to confirm you have the proper medical record documentation supporting the information that you report. Thank you.
Great, thank you for that. Our next question asks, we are reviewing the CMS guidelines for Falls 2, and it says that Falls risk assessment should be addressed in the provider notes, but the CMS guide says the clinician can do it. Oftentimes the nurse asks these questions. Does this count or does it have to be the provider?
So for Falls, the measure isn't limited to a particular clinician type. CMS doesn't specify the internal workflow of clinicians or groups or virtual groups and ACOs. The quality action just has to be completed by anyone the organization considers qualified. Thanks.
Great, thanks so much. So our next question from the Q&A asks, we have a male patient marked as female that is ranked for the mammography measure. We were advised by the help desk to change the patient's gender to male in the web interface. What would the implications of this be? Would the patient be skipped, or would the patient be removed from the measure and alter everyone else's rank?
Hi, this is Katie from the PIMS team. I was the one that had sent you that information. So if you do change the patient's demographic information in the web interface for Prev 5, the patient will be treated as a skip for that measure, and then you would need to report another patient in their place. Thank you.
Great, thank you so much for that response. And we will look again at the phone line to see if there are any hands raised. Looks like we have a couple folks with their hands raised, so I do want to make sure that we get to you. So Ramonda Mowdy, if you would like to ask your question, I will go ahead and unmute your line.
Hello, can you hear me?
Yes, we can.
Alrighty, so I have a question about Prev 12. And if a patient, this is for the diagnosis exclusion, we have a couple of patients who their diagnosis to exclude them is from previous years like 2017, 2018, or prior. Can we use those diagnoses if we do not see them in the measurement period?
Hi, this is Katie from the PIMS team. So I think this question is going to require a little bit more investigation on our part. So we would ask those of you with this question to submit that to qpp@cms.hhs.gov, just so we can ensure that we're giving you a thorough response.
Okay, thank you.
Thank you.
Great, thank you for that question. So we will now move to the next attendee with their hand raised. So Prathima Pichera, I'm going to go ahead and unmute your line so that you are able to ask your question.
Hi, can you hear me?
Yes, we can.
Yeah, so my question is regarding the hypertension blood pressure measure. I have seen in one of the web interface supporting documents that the most recent blood pressure reading has to be from the providers that are included in the ACO. So what if we have the records from, other places too? Do we have to make sure if that's the most recent one that we have, they are actually our ACO providers?
So for this one, if you could, because I'll need to further research this since it is ACO specific, could you please open up a help desk ticket so I can further review, I suppose, what is the response for this, so I'm not telling you incorrectly.
Sure. Yeah, I will send in a response, email you. Yeah, thank you.
Perfect. Thank you so much.
Great, thank you for that question. And it looks like we have a couple more questions on the line. So Susan Helton, I'm going to go ahead and unmute your line so that you can ask your question. And you will need to unmute yourself as well. Maybe having some technical difficulties, so we will come back to that question. But it looks like we do have another hand raised. So Sumita Mathur, if you would like to ask your question, I will go ahead and unmute your line now.
Thank you. Can you hear me?
Yes, we can.
Okay, awesome. My question is regarding the depression screening measure and follow-up measure. I just wanted to confirm that does the qualifying encounter need to be an outpatient encounter? This is, I'm looking at one of the patients in the sample who had, the only visit that they had was an inpatient encounter with a PT evaluation done in the inpatient and a CPT code, a 99 CPT code dropped for that PT evaluation. Does that, and that was the only qualifying encounter that was picked up by the system. But does that really count as a qualifying encounter, or does it need to be an outpatient PT? Do you want me to repeat my question?
This is Kara with RTI. We can respond to that via the help desk.
Okay, thank you.
Great, thank you so much for that question. So we've got a couple other folks with hands raised. So I'm going to go ahead and unmute your line, Cindy Burton, so you can ask your question.
Hi, can you hear me?
Yes, we can.
Okay, perfect. So earlier guidance was given on the PREV-12 depression screening that if the provider does not document if a PHQ-2 or 9 was positive or negative, that we should mark that the screening was not performed. But the web interface document question flow is, was the patient screened for depression? Yes, no, exceptions or NA. And then to answer, was the screening positive for depression? Would we not mark yes to the patient was screened and then NA to the patient was positive for depression?
Hi, this is Katie from the PIMS team. So, sorry, I'm just taking a look at the flow here again quickly. So in this particular instance, I'm gonna actually recommend that you send your question on to qpp.cms.hhs.gov. I mean, how the patient is treated in terms of the measure flow. If you're answering yes, the patient was screened, but they wouldn't have the proper interpretation of positive or negative to go along with that, which doesn't entirely fit with the flow either. So just so we can look into this a little bit further, we would have you submit your question to the service center, and we can do a little more digging for you.
Okay, I appreciate that. And I guess my follow-up question for that would be, in what case would we use the NA to was the screen positive for depression? So I guess the wording of it is just kind of confusing.
Okay, yep, we can definitely take a look at that. And one other recommendation, just to make sure, this is probably a good reminder for anyone submitting questions, if you can include the information that you're reporting using the CMS Web Interface and be specific about which measure you're asking about, it will help your case get to us just a little bit faster and avoid some of the back and forth that may be required. So if you can include that information, that would be helpful. Thank you.
Well, thank you so much for that question. I think now we're going to go back to questions submitted through the Q&A box and get through a few more of those. So the first question that we have submitted through the Q&A box is a clarifying question about the PHQ-2 score, and the question asks, can a PH2Q score of 0 count as remission?
So this is Katie from the PIMS team. Just to kind of clarify that PREV-12 is the only depression screening measure that allows for the use of the PHQ-2. I think this caller might be confusing MH1 as well. That measure utilizes PHQ-9 and measures depression remission. So in terms of satisfying the measure for PREV-12, we would be looking for that depression screening with the documentation supporting a positive or negative, and if positive, a follow-up plan is documented. For MH1, we are measuring the percentage of patients with major depression or dysthymia who reached remission at 12 months plus or minus 60 days. And this particular measure utilizes the PHQ-9 or PHQ-9M. Thank you.
Great, thank you for that clarification. So the next question that we have is, for MH1, the problem list shows F32.9, which is the ICD-10 code for major depression. However, the description in the problem list next to F32.9 says depression. Can we accept this on the code alone?
Hi, this is Angie. So for clarification on this measure, I saw several questions asking, or several similar questions asked. So if you look on page 9 in Denominator guidance, you could find this in writing, but it does say that the diagnosis of major depression or dysthymia, diagnosis code on the encounter or problem list, and then in parentheses it says regardless of vendor assigned description of the code, so it can be used. F32.9 is indeed in the MH1 coding document for denominator diagnoses. So if you do have the code, regardless of the description from the vendor for F32.9, then it would be acceptable as verification of the diagnosis. Thank you.
Great, thank you. So we have another question here in the chat box that says, For MH1, I have a patient that I am reviewing that has a history of depression documented during the identification period. However, the patient scored a 0 on the PHQ-2 question, therefore a PHQ-9 was not completed. How do I navigate this? Throughout the measurement period, the patient has scored a 0 on her PHQ questionnaire in the office, therefore she did not require having the PHQ-9 done per the office protocol at that time.
Hi, this is Andy again. So for the MH1 depression remission at 12 months measure, the only tools that are acceptable are a PHQ-9 or a PHQ-9M. So, and part of the denominator criteria is that the patient has to have one or more PHQ-9s or PHQ-9Ms administered during the denominator identification period to be included in the measure. So if they did not have a PH9 or a PHQ-9M, then they would not be included in the measure. A PH2 would not qualify them. Thank you.
Great, thanks so much. And we have time for a couple more questions. So the next one that has gone through the Q&A box is, if the diagnosis in the look-back period for MH1 is major depression, incomplete remission, would we count that as a qualifying diagnosis?
I'm sorry, could you repeat that?
Definitely. So this question asks, if the diagnosis in the look-back period for MH1 is major depression, incomplete remission, would we count that as a qualifying diagnosis?
I think it'd be best if you could submit a case to the QPP on this one so that I can look into it a little bit further. Thank you.
That's great. Thank you so much. So our next question then asks, the DMAC1 suppression for 2021, we got an email from CMS telling us that this QM for 2021 would be suppressed, meaning we would not be scored on it. Since CMS failed to publish the new DMAC1 value codes for 2021. I think this is just a clarification question.
This is Kara with RTI. I believe that measure suppression is specific to the claims measure submission method, but it does not apply to the web interface submission method. So the measure is part of the performance measure set for 2021.
Great, thank you so much for that clarification. So we have a couple of minutes left, and I want to make sure that we get to everyone on the line. So we have a couple more folks with their hands raised. We've got time for a couple more questions on the phone. So Sandy Santangelo, I see that your hand is raised, so I'm going to go ahead and unmute you now.
Thank you. Yes, and my question is really pretty much the same as the last question, because I'm looking at the guidance that we received on diabetes hemoglobin A1c, and it talks about the measure being suppressed, and it does not, I don't see where it says specifically claims submitted. I don't know, I guess I just wanted to make sure, because I had a different impression. I thought this was a pay for reporting measure for this year. So I just needed that clarification as well. So.
This is Carol with RTI. If you want to submit a ticket to the help desk, we can provide the exact citations and source documents for that guidance.
Okay, thank you so much. Appreciate it.
Thanks so much. And we've got one more question on the line. So Susan Helton, I'm going to go ahead and unmute your line now so you can ask your question.
Hi, thank you. For Prev 12, I know that it talks about patients who live in a long-term residential facility are excluded, and that assisted living is not considered long-term or residential in that regard. Is that true for anywhere else in these measures where it says long-term residential? I guess my question is at any time is assisted living considered a long-term residential situation? Were you all able to hear me?
Yes, we can hear you. Can you repeat your question?
Sure. For mental health 1, not Prev 12, excuse me. Permanent nursing home resident, talking about a patient who's residing in a long-term residential facility, but that does not include assisted living or group home settings. So anywhere else within these measures where it might say a long-term residential situation, is it true that assisted living is not considered to be long-term residential?
Hi, this is Angie. Yes, per the measure specifications, it does not include patients who are receiving short-term rehabilitative services following a hospital stay, or patients that reside in assisted living or group home settings. So those are not included in the exclusion.
So that would be true. I think it does. That would be true for any measure that has that as an exclusion, correct?
If the measure, yes, if the measure specifications state that. You can see this in the MH1 2021 measure specs on page 10. There's a definition of permanent nursing home resident and information about the denominator exclusions. You can find that there.
Thank you.
I'm not sure if all the specs. I'm trying to think of other measures that have permanent nursing home resident as an exclusion. I can't think of any right now, but it would have to say that. We can't make a blanket statement for all measures.
So I just need to check the specs for any time it says that.
Yes, please.
Very good. Thank you.
Great, thank you so much for that question. And that is all the time that we have for Q&A this afternoon. So with the conclusion of the Q&A portion of the webinar, I will turn it back over to Lisa Marie Gomez to conclude our call this afternoon.
Thank you all for joining us today. The PowerPoint presentation, recording, and transcript from today's call will be available on the Quality Payment Program webinar library within the next 2 weeks. As a reminder, our next support call is scheduled for Wednesday, February 9th from 1 to 2:30 p.m. Eastern Time, during which we'll cover frequently asked measure questions regarding Prep 7 and DM2. We hope you all will join us. Thank you all and have a great day.